Hey everybody, this is Dr. Donish.
This is Dr. Escaloni.
So, we had some technical difficulties again.
Mm-hmm.
Seems like every week we've got some new technical difficulty.
Mm-hmm.
Anyways, pain management has become a factory designed to turn its struggling patients into lifelong customers. I'm Dr. Donish, a native Kentuckian and the visionary behind Wellward Regenerative Medicine. As a Johns Hopkins trained double board certified anesthesiologist and regenerative pain specialist, I believe it's time to bring true healthcare back into medicine and offer you, the patient, the healing you deserve. This 50 Shades of Pain show is one way we empower you, the patient, to receive sustainable treatments for injury and pain without surgery, addictive medications, and without being a victim of the system that's designed to work against your healing. Start your healing journey at wellwardmed.com. Today I'm here with my co-host, Dr. James Escaloni, who serves as a physical therapist and physician extender at Wellward. Like myself, he's seen firsthand countless of patients who have suffered unnecessarily, not for lack of qualified or caring doctors, but from a broken healthcare system. So James, what are we talking about today?
It's a good topic today. Today we are talking about opioid drugs. So, everybody's heard about these things. They hear about the the epidemic of opioid drugs, and they think about, oh my gosh, why are even people taking this? And there's all these addictions going on with it. But then on the other side, you hear from people who say, those things saved my life. How can something be so good for so many people, but cause so many problems for so many other people? That's what we're going to try to get into today. What are your thoughts on this, Dr. Donish?
So, opioids are long been around. Opium was the first pain-relieving medication, and for a long time, it was the mainstay for helping people deal with pain, particularly in the acute setting. But then in the 1980s, the concept of we're not really addressing pain sufficiently across all of healthcare, and the reality was we weren't, because a lot of people who were particularly at the end of their life were really struggling to get adequate pain control, and there was a stigma around using these medications. So there was the political will and the special interest support to really endorse greater use of opioids, but it was an overreach because they started to not just apply it for more aggressively in acute pain issues, like if somebody comes in with a broken limb or has a car accident or is undergoing surgery. Not only were they using it in palliative care or in malignancies like treating people with cancer, but they started to use it more and more for people who have chronic problems like osteoarthritis or back issues or headaches or fibromyalgia. And the problem with that is that these medications have a short duration of impact, meaning that if I give you some pain medication, you're going to get some pain relief. But if I keep dosing it over and over and over, it becomes problematic because of two reasons. One is your brain starts to adapt to the presence of that medication. The other is that you start developing a tolerance to it. So one is positive, one is acting in the positive way and one is acting in the negative way, but both of them are causing you to become more and more resistant to the impact that the opioids have. So, for instance, the example I use is that whenever your body generates a pain signal, like if I punch James in the leg and he has some pain, what's happening is that there's an initial impact in his leg that sends a pain signal up to his brain, and that pain signal is telling the brain, hey, something's going on that needs attention here. Now, when it gets to the brain, the signal splits into two directions. One goes to the conscious part of your brain, and one goes to the part of your brain that reacts to different stimulus, like it needs to know that you're in pain. So one sees the pain signal, and one cares about the pain signal. Pain medication only affects the part that cares about the signal. It doesn't really affect the part that sees the signal is there. And these two need to talk to each other. If it doesn't, then the part that cares about the pain signal is not giving feedback to the part that sees it, and the seeing part will say, hey, message not received, I'm going to turn the volume up. So over time, there's an increasing sensitivity to pain because your brain says, I need to be aware of any pain that's going on in the body. And if I'm not getting that signal feedback, then I need to turn the volume up. The other side of the fence, that negative side of the fence, is that your brain is also getting tolerant to the effect of the medication. So as that medication is there in the brain, your body's developing other workarounds for it. And so you need higher and higher doses to get the same effect. Does that make sense?
Okay. So it sounds like if you take this medication that's not working on both of those, your body's going to turn up the volume just to hear whatever's coming from the body, even though that medication's kind of blocking some of the signal, but not from the right pathway.
Right. So it only affects part of the whole system, part of the whole equation. It's not affecting the entire system. So, in other words, the only way to get your brain to react normally is if we were to take away that pain signal being generated. So, essentially, this is what's happening. If somebody is taking a pain medication, this blue line represents somebody who is not taking any pain medication. And over time, you see that everybody who's had some pain issue knows that there's an up and down course to the pain. Like, you stand up on a twisted knee and it's going to hurt, but when you sit down, it gets better. So you have this up and down course to that pain. The dotted line is kind of the average of that pain. Now take the same person and put them on some pain medication, and when they do take the medication, yes, they do see a reduction in their pain, but as that medicine wears off, it doesn't go back to their normal baseline. You actually have a rebound effect, and you become more sensitive to pain for a period of time. And so somebody who's been taking medication around the clock will see this heightened pain level and think, oh, it's my condition that's worse, so I need to redose my medication. And sure, they do take it, and the pain level comes down. But then, as the medicine starts wearing off, you go back into that rebound state. And this, over time, you're seeing that the depth of the pain control gets less and less and less over time, and the tolerance continues to be there. So overall, the average pain level that the patient with pain medication gets is actually increasing over time, and they're not really conscious of it because their brain is not going to have the awareness of comparing this moment to the next. So their sensitivity of pain goes up without them really even being aware of it.
Wow, that's pretty intense. So if this is what's going on, how long have people known about this effect?
It's been known for a long time. In fact, there are studies going back into the 1980s that when you take even the first dose of pain medication that you take, your brain cares less about the pain, but your sensitivity to pain actually becomes more sensitive. So there's this great study where they put your hand in really cold water and see how long you can hold it there as an indication of people's tolerance for pain. And even when they dose a pain medication, even if I were to give you, like, let's say I put your hand in water and just time how long it takes for you to pull your hand out, then I give you some pain medication and I do the same thing. Well, you would expect that you'd be able to hold your hand under water for a longer period of time. But it's not the case. You actually have less ability to maintain your hand under cold water because in some capacities your sensitivity to pain has gone up even though that pain medication is on board. The problem is that we think of pain as just one entity, and it's multiple different types of pain. So like, for instance, the pain you feel when you cut your finger, or if you take that cut and you pour lemon juice on it, or you take that finger and you touch it on a hot stove, or you go to pull out a kitchen knife and you slam your finger in the drawer. Each one of those is called pain, but each one of those has a different nature and characteristic and processing in the brain. Opioids are only good for certain types of pain. They're not good for all types of pain, and the challenge is that when you're dealing with a chronic issue, you're really dealing with a mixture of all these different types of pain because the body's evolving around that condition. that's why the whole name of the show is 50 Shades of Pain, is because pain is not just one entity, it's multiple different entities. And to get a better understanding of how we can treat it, we need to look at the bigger picture of it and not think that opioids are the one-size-fits-all solution.
So if this has been well known for a while, why do you think it's been so widely prescribed across the country?
That's a controversy because if you ask me personally, I think it's special interest. I think that there were a lot of people who had a vested interest in selling more pain pills. And so it became common knowledge, even though it was against the scientific evidence. And people who came out and said, hey, we need to pause and look at this, they were marginalized in that era because they were perceived as being cruel or backwards thinking or opiophobic. So there was a stigma about pain and how you treat it, and the stigma was so deep that the scientific knowledge became backdrop, and what was said and told and conversed about was kind of the more mainstay, in-your-face arguments that were being heard. It created an echo chamber. Like if 50 people on one side are saying one thing, that opioids are good, we need to be using more of them, and a couple people are over here saying, wait a minute, let's pause and think about this a little bit deeper. It's hard to get the 2 people to match the same weight as the 50 people. That's why this is so important, is to have these conversations, because we need to dispel the myths about opioids. I'm not against opioids. I'm an anesthesiologist. I use them all the time. But there's a time and a purpose for it, and if you overutilize that, it creates this illusion of benefit that's really harmful.
So when you're saying it's harmful, I've heard that a lot of people have been dying with this. Is this trend still going on?
Yeah, it's. I mean, if you look at it, and this is particularly concerning, because we had. At first, it was a lot of the standard opioids that came to the market, and then heroin started to replace that. But now, more recently, fentanyl, which is a synthetic opioid, is just skyrocketing because it's so cheap and it's so readily available that particularly this goes up until 2017, but the data for 2020 is showing actually one of the highest increases that we've seen in history, and it's because once people are exposed to opioids, there are two different problems that evolve. One is the addiction, which is what gets all the press because we see all the deaths happening. And in the past year, we've gone to 88,000 deaths that happened during the pandemic as a result of opioid overdoses. The other part of the equation that's not talked about as much is just the dependency and the damage that it causes on the brain and how the brain processes pain. The addiction is very evident. It's very obvious because it's so in your face. And the fact that we're seeing such a spike in addiction or such a spike in overdose is indication that social stressors and the anxiety and the mental health issues that surround the pandemic are driving that addiction. But it's not necessarily driving the physical dependency that other people feel with opioids. So that's why I kind of tease these as to two different problems. One is addiction, which we need to be addressing, but the other bigger problem that's more insidious and probably affects many, many more people is what are the long-term impacts of very safe, very normal, very standard of care prescribing patterns where people are taking 2, 3, 4 pills a day and they're functioning, they're going to work, they're doing the things that they want to be doing. The conversation that's not being had is that that's having an adverse impact. It's having a harmful impact on how those people can deal with or how they address the physical presence of pain.
But didn't you just say that that's harmless and they take it 3-4 times a day and that's the standard?
Seemingly harmless. Because on the surface, they're still out there, they're still functioning, they're still doing things. And some people aren't, but some people who take pain medications on a regular basis are doing all those things, but what's not being conversed about is that their quality of life actually suffers in the long term when they're taking opioids. It's not evident because when they reduce their medications, the quality of life degrades rapidly, and it's because they've developed that tolerance or dependency to the medication, and it's the absence of the medication that makes them feel bad, not the presence that makes them feel good. There's a reason. So, despite the fact that we've grown so much in how much opioids we use, in every demographic and in every age group, there has been a progressively increasing sensitivity of pain and decline in quality of life. And other than opioids, there really isn't another reason. Here's another graph that's interesting. This looks at the number, it looks at different countries around the world and what people note as quality of life in terms of managing pain, like the presence of pain, how bad it is, and how prevalent it is. And you can see that the U.S. is bottom of the list. It's the worst of the worst. And as 5% of the global population, we're using about 80% of the global opioid supply. So that only makes it, there are one of two scenarios that are possible in this. Either we have a population that is genetically more prone to having pain problems, therefore we have more pain, so we take more opioids, or that the opioids that we're taking is actually what's contributing to our declining quality of life, to our ability to manage and deal with pain. Given the fact that we're a melting pot, we're genetically mixed from all over the world, situation A is not possible. Like, we are not genetically more damaged or more prone to dealing with pain. It's the lifestyles and the methodology that we have utilized to manage pain which has been the problem. That's something that we need to address, because it will, once somebody is in that pipeline, you're really dealing with two problems. One is the original pain problem, but now you're also dealing with the neurologic changes that are taking place as a result of those opioids.
So this is why a lot of people just end up in this cycle for a long time. They thought they had the medication they needed, and then all of a sudden they can't stop because things get so much worse if they're off of it.
Exactly. It to me, the travesty is it sets people up for this cycle of hope and despair. Like, if you come into the doctor's office and you say, "Hey doc, I've got this problem," and they write you a prescription and you go home and you start taking it, for the first month or two, you're going to feel great. Opioids do work. They work in the short-term setting. But after that time frame passes and your body starts getting used to that medication, it's going to work less and less and less. And it gets to the point where you can't tell the difference between when you were taking it, when you're taking it now, and when you weren't taking it before. They just kind of all blend in together. And it gives the illusion that when you're taking it, you feel better, but that your condition is what's getting worse over time, not that the medication is what's making you more and more sensitive to pain. So it creates this illogic in the brain that's not really evident when you're taking it. It's only evident when you see the long-term outcomes and the big picture of everything.
I see. So about how long does it usually take for somebody to go from that cycle of this feels good, I'm feeling better, to I cannot live without these?
So it only takes 3 days for your body to become used to the presence of the medication.
3 days?
After 3 days, your risk for staying on the medication, even if your problem resolves, starts to spike. After 30 days, 30% of people who've been taking an opioid for the first time ever in their life, if you take that medication for 30 days in a row, your likelihood of staying on that medication is about 30%.
My brain is blown from that information. Do other physicians know this?
It's shockingly uncommon knowledge, despite the fact that, if you were to say, hey, I'm going to prescribe you a drug, that 30% of the people who take this drug consistently over the course of the month will never get off of it again. Or I'm going to do a surgery on you in which 30% of the people are never going to get better again. you would think twice about ordering that. But it's just become such a common method to treat pain with pain medication for a long period of time that we don't think about that anymore. A lot of states are passing legislation to limit how many days somebody can be prescribed a medication without having some kind of a review afterwards. In Kentucky, for instance, if you've never been on pain medication before, the law says that 7 days is all you're going to get, unless a doctor has a really justifiable reason, and they have to make that explicitly clear. And I'm fine with that, because there are situations in which, yes, you're going to have an issue that goes on for that long. But they're rare. They're very, very uncommon. The typical way the body responds to an injury is the first 72 hours is the worst. That first 72 hours, you're going to have high peaks of inflammation, high sensitivity from your nervous system. Your body's going to be in red alert. After that 72 hours, you get this steep drop-off in the pain, and that can linger for about 2 or 3 weeks. And then after that, you get another steep drop-off, and things hopefully normalize. The issue is that if your pain is going on for more time than that healing cycle, there needs to be an evaluation to figure out what else is going on, because there are so many conditions that evolve into chronic pain unnecessarily because they were just brushed under the carpet with pain medication and the underlying problem was never really resolved. Those issues just accumulate damage and become chronic problems as opposed to something that could have been addressed in that time.
Wow. So let's say you've got somebody who's been given some pain medication for some back issue, and they've been on it for maybe 2-3 months, and they're starting to notice that this is becoming a problem, and they come to see you. They've seen this podcast, and they're looking to make their lives better. What's their first step?
So we want to understand why that pain is there to begin with. Pain doesn't happen in a vacuum. It's because something is wrong in the body that we need to understand and fix. And the challenge has been that for such a long time we've gotten used to treating pain with pills that a lot of the diagnostic process has just become backseat passengers to the whole pain symptom process. So you're not going to be able to get to the root of the problem with just getting an X-ray or an MRI. You may not even be able to get it with examination and movement manipulation, but you can get a much better idea if you can do more thorough diagnostic evaluation like what we do here. Most problems that people face are self-limited. They're going to get better on their own. So there's a very strong argument to be made about just getting those patients to the right physical therapist and get them moving better and start normalizing tissue movements around an injury, and eventually that injury is going to be self-limited and heal itself. If it's not, that's when you really need a good expert pain specialist or regenerative specialist to do what we term in our office as pain mapping, where we build an idea or a concept around what could be causing this pain, and then we move systematically through those options to figure out what are the intricate pieces of your pain. It's not as simple as saying back pain is back pain. Back pain is a constellation of different problems in varying permutations. Like there's a lot of different combinations of things that can happen to cause the same feeling of pain. And if you just brush it all under the carpet with the medication, you're just not going to get to the root of the problem or ever find a resolution for it.
That sounds really helpful for a lot of people. I think one thing that if I was a patient and I was going through this process, I'd be nervous about coming to you and you saying, well, I'm not going to prescribe you any medication. Is that what will happen to a new patient coming in?
Not at all. No, because two things. One, I know that once that dependency is formed, it's not easy to come off of it, and I'm not going to yank the rug out from under anyone. We push the margins and try to get you to a point of what we call a non-daily dosing, meaning that you have a handful of pills that are available to you at your worst state in your worst moments, but for the most part we're working around it. We're figuring out other ways of addressing it. There was a Greek study that was done that showed that the combination of ibuprofen and Tylenol was just as effective as oxycodone, which is a really powerful pain medication for certain types of pain. We've just gotten into this notion that pain medication is a necessity, and it's not always the case. So if we can get somebody to a point where we can step it down progressively and get them to a point where it's not a daily necessity, that's the goal. That's the goal. It's not to eliminate these medications off the face of the planet. It's to just step it down to a point where it's not a daily routine.
Wow. That sounds a lot better than just going in and just cold turkey for any sort of medication.
And I certainly wouldn't do that. I wouldn't recommend anybody doing that because it is so difficult to adjust back to a normal baseline. It does happen for most people. Most people are able to get off of pain medications and even get to a point where they don't even need that occasional dosing. But for some people, the adaptation has taken place over such a long period of time and at such intense doses that really the damage has been done and you can't get them off of that. In those cases, there are some other ways to mitigate the risks, but we don't want to push the margin so quickly or so hard that it becomes a discouragement to the patient, because these are difficult scenarios. And particularly when they've gone through this hope and despair cycle, the main thing we want to instill upon people is your body has the capacity to heal. It's a resilient, rubbery machine that gets hit and it can bounce back, but it will only bounce back if we treat it the right way. It's not going to bounce back if we just kind of numb it and ignore the issues and let it just fester.
So for some of those people who are stuck in that hope and despair cycle and they're a little bit more on the despair side and they're coming in, it seems like they just can't get out of that hole. What do you usually do to help them?
Yeah, one of the cool tricks that we've evolved in our practice is using ketamine. Ketamine is an old anesthetic, but in the brain, when the body's adapting to the presence of opioids, there are 3 different receptors that are activated. Ketamine blocks one of those 3 receptors, and that has a rapid effect on reducing the tolerance of opioids and even detoxing them from the necessity of opioids. I had a patient who was on the equivalent of 900 milligrams of morphine. Now, to give you each day, to give you context, if you had surgery, they would write you for like 5 milligrams or 10 milligrams to take at a time, and maybe no more than like 2 or 3 times in a day. This gentleman had been ramped up over time to the point where he was on 900 milligrams of morphine every single day.
Oh my gosh.
Yeah, enough to kill a horse.
Oh my gosh.
And he was miserable. I mean, his sensitivity to pain was astronomical. You would just touch him or scratch him, and his skin would have this lingering feeling of pain after that. So the first infusion of ketamine that we did on him, he went from 900 milligrams down to 30 milligrams.
Oh, wow.
And then the second infusion that we did, we went from 30 milligrams down to 10 milligrams. Now, each interval that you come down, the closer you get to 0, the slower you have to go and the harder it gets. But going from 900 down to 30 is a massive leap. It wasn't easy. He worked hard at it. But now he doesn't even take pain medication, and his quality of life is radically better in spite of all the fear and hesitation that he had coming in, thinking that the medication was a godsend. It was his necessity. But it was just this illusion, because every time he tried to step it down, it was this incredibly horrific pain. And people were not designed to deal with or live with that level of pain. Like, it's just not, low back pain will never hurt the way a chronic opioid-dependent patient will hurt if that medication was taken away. It's a matter of getting their brains to processing pain normally again in order to really address the full picture of the problem. We also want to figure out what's going on with the pain. We also want to fix what's going on with the back that's causing it. But part of the way we have to address it is to get them back to normal in terms of how their brain processes pain signals.
This is really helpful. I think that a lot of people hearing this right now will start to think of people at home who could probably use it, a friend or a neighbor. So if somebody wants to come in and actually have this conversation with you, what do they need to do?
Best way is to get a referral from your primary care, because a lot of insurances require that. But if you're strictly looking at regenerative therapies or things that are outside the box, and we're not having to deal with the bureaucracy of insurance, you just come in. We'd be happy to see you. But if we're trying to get insurance approval for it, the best way is to get your primary care to send us a referral, because a lot of insurers require that.
Okay. Is there a website that you'd recommend?
Yes, you can go to our website, wellwardmed.com. Our Facebook has a lot of information as well. I know this is probably going longer than our usual talks do, but we will be doing this on a weekly basis, and over time we want to accumulate a massive information out there, because what's out there is not sufficient. I mean, if you get this book, we are not making any money off of the book. It's just there for public information, but you can get it on Amazon for $1. It'll explain the process and the mindset that we have around pain and what we envision as really being the future of what pain management should have been a long time ago.
That's pretty wonderful. I think that's going to help out a lot of people.
Yep, and if you guys have any questions, I know this is controversial. I know that some people will be hurt by this. We do not intend to harm people with this. It really is something that over time will make a big difference, but in the short run is a very difficult transition. And if you have any questions about it, feel free to message us on Facebook, on Instagram, on our different platforms, and we'll be happy to talk in further detail about this.
Absolutely. That's wonderful.
Well, thank you for watching the 50 Shades of Pain show. Each patient is different, and there are numerous factors that can contribute to your pain. In the same way, we recognize each patient as individuals and create treatment plans designed specifically for your health. Our Wellward team looks forward to partnering with you. I'm Dr. Danish.
I'm Dr. Escaloni.
And we encourage you to start your healing journey at wellwardmed.com.
Thank you.
Thank you.